So-
I did it.
That's not fancy.
Thank you. Good job. Okay, so we have Dr. Zoe Cole, and I'm going to let her talk about herself a little bit.
I still can't get over that, but it's real. So, okay. I'm Zoe. I think most of you on here know me already. I just graduated in May, obviously, with everybody else, and I'm going to Conemaugh in Pennsylvania, which was my number one. Originally from Pennsylvania. I did my 2 audition rotations at Advent Health in Orlando and Riverside Regional in Virginia. I'll talk about those later. Beyond that, I'm a mom to an 11-month-old. I had him in my 4th year of med school. I am an at-large board member for AAEM. And what else? I applied to 108 programs. I got 37 interviews. I accepted 17. And yeah, that's me.
Nice. Okay. Congratulations. Jared, are you here yet?
Yeah, I'm here. Can you not hear me?
No, we can hear you now. Yes.
Okay.
So this is
Hi.
Dr. Jared
Oh.
Mayfield.
Hi, I'm Jared. I did my EM electives at Sinai in Chicago and at Altman in Canton, Ohio. I matched at Henry Ford Macomb. It's part of the Henry Ford Health System hospital in the greater Detroit area. I think I had like 15 or 16 interview invites. I went on all of them, ranked all but one, I think. That's pretty much it. My room's a bit dirty if you can't tell. I'm moving. I'm moving out tomorrow, basically. So fun times.
Well, congratulations to you, and I'm thankful that you showed up while you're moving. We appreciate you. And then this is Dr. Marcus Robinson.
Hey y'all, the Texan here. So Marcus Robinson just graduated with Zoe and Jared a few weeks ago. I did my EM rotations at Riverside, same as Zoe. Also at Advent. No, I didn't copy her. We just happened to just individually plan this, and then when we talked about it, we kind of had the same plan, which was very interesting. And then my 3rd rotation was at the Brooklyn Hospital Center. And I mastered my number 1 choice in Orlando. I'm going to Disney World, so I'm excited about it. I applied to only 45 programs and ended up with 21 interview invites. Only took 13 of those. So yeah, good. I'm glad y'all have us.
Thank you. Congratulations to you. Okay. So before we get started and we start talking about slows and stuff, we just wanted to talk about the different kinds of slows. Obviously, I'm still in medical school, so this is what I know. If you guys know better and if you guys would like to speak on it, that would be fine. And then if not, we have the link for like more details. This is just like a snippet of what it said on that website. But basically, we want an E-slow or a slow, essentially, is the goal.
Get all E-slows, y'all. E-slows only, please. Only get E-slows.
Unless you can't.
Yeah.
Unless you can't.
Yeah. I was gonna say, I'm in the EM Discord. I don't know if anybody likes or like goes on Discord at all, but there's an EM like Discord that has all this information on it. And actually Zoe's PD or APD is in there as well. And he was saying that if you have 2 E-slows, you like you're fine. Like you have your golden tickets, you don't have to do nothing else. But sometimes, especially being a raw student, like you can't always get 1 or like 2 E-slows. You can only get like an E-slow and a slow, like I had. So, but the point is, if you get 2 E-slows, you're fine in terms of letters.
We have lots of questions.
Yeah.
They're coming.
Yeah.
It's one of the.
Jared, I know you broke it down for me pretty well when I had the question. Like, do you mind just like going over quickly like what each one is? Like just really briefly. Like it doesn't have to be super in depth because everybody can look, but you broke it down for me pretty good one day.
Yeah. Yeah. So basically, like, an ESOL comes from a program director or like a program itself, that has a residency attached, like in the rotation that you're doing. So like if you go to Tacoma or if you go to Altman, you go to Advent, these have EM residencies, and they'll give you the E slow. But if you go to Sinai, for example, even though that they have residents from Rush, from Resurrection, Sinai does not have an EM residency. They have EM attendings, and that's where you get a normal slow from. Same format, just it's not done by a program. And then your subspecialty is like ICU, but only done by a EM physician that has a fellowship in ICU. Ultrasound, EMS, toxicology, that kind of thing. OSLO's off service kind of thing is like another same formatting as a slow, just nicer way to read, because EM people don't like to read stuff. So yeah.
Thank you.
I have a question about the slows. Is there anybody who matched successfully with one e-slow and one in the regular slow, the one that comes from the one without the residency program? Because I'm somewhat in that position. I'm applying this cycle, and because of finances and just other things, I could not apply to get 2 electives at the hospitals with residency. So I have one e-slow, which is going to be from the programs with the residency and so on, and have one on the regular slow that came from an EM department, but no residency. They have a family med, but not an emergency medicine residency.
Zoe or Marcus, did y'all have that, or did y'all both have 2 e-slows? Because I had that. I just want to.
I actually had 3 e-slows.
Okay.
Yeah,
So
just because the guys that I had spoke to that had matched the previous year, they had told me that to get as many e-slows as possible, like at least 2 to 3, just because I didn't have a home base for emergency medicine. So I just went ahead and just got 3 just to make sure and show up everything.
Be careful with that, because some programs think you're taking from other students if you have more than 2 slows. Anyway, Jared, answer her question first, and then we'll talk about that.
Yeah, so Jody, I actually had one e-slow from Altman, and then my slow came from Sinai, and then I had an O-slow from an anesthesia elective, and I did fine. Yeah, I did fine.
Okay, thanks. Because I was panicking a little bit, because I'm like, do I want to spend extra? Because I know you could do electives at hospitals, but because being that I finished my rotations with the school, I would have to pay out of pocket per week, and I really don't have the money. And I figured everybody's like, oh, you need to get 2 e-slow, so I was panicking a little bit.
Right, and then like that, and that was my kind of thought process too. I didn't want to pay Ross extra money, so I decided just to go to Altman and just do one at Sinai, and then it worked out for me. So
okay, thank you so much.
Okay, the only other thing I wanted to add was a lot of programs expect you to have 3 letters, not 3 slows, but I did not know that. I don't know if I was just like oblivious, but so I was like scrambling at the last month or so to get a 3rd letter just from anyone. You are expected to have 2 slows in whatever form they may be, and then a 3rd letter. And I asked an EM attending, but I think you can ask anybody. Something that I do think benefited me was I asked somebody who I knew was really well known in the emergency medicine community, because I got the chance to work with them. I think that did help me. It came up in my interviews a lot, but just be prepared that you need a 3rd letter, because I apparently didn't know that.
Okay, thank you so much.
Okay, so we kind of went over how many slows each of you submitted. So Jared did 2, and Zoe did 2, and then Marcus, they did 3 e-slows. With that, and so Jared did 1 e-slow, 1 slow, and then you guys both did all e-slows, correct? When you do 3 e-slows, like how Zoe was saying, when you submit, like, don't you have to click 3 letters only? So did you do 2 e-slows and then 1 per other letter? Or you just did all 3 e-slows and that's it?
No, I just did all 3 e-slows, and then I actually had a 4th letter too as well from my surgery sub-I that I submitted. So basically, I had 4 letters total. But yeah.
Okay, and then I guess we kind of touched on the benefit between e-slows versus o-slows. If you guys want to go over that a little bit more, if there's anything else to add to that. No? Okay. And then should we aim for 3 slows or slows period?
Zoe's saying no, and I know Jared's gonna say no. It just really depends, because
Yeah.
if you do one slow and that rotation doesn't go well, then you're gonna be, you're gonna put yourself at a disadvantage, because you know how the ranking system goes. It goes like top third, middle third, and bottom third. So if you got an slow and you're bottom third on that one, and then you only have an O slow, that's not gonna be a good look, So you kind of want to, you kind of want to do something about that. Maybe get a second chance and potentially get that third one somewhere.
That's the only exception I would make.
I will say in retrospect, even though I was okay and I didn't really worry about it given the rest of my resume, I will say in retrospect, I wish I would have done another pure EM elective for another ESLO, because the thing I noticed between my colleagues and myself, the people who got like 40 interviews had at least 2 ESLOs. I'm not even kidding. Like everybody I talked to had a minimum of 2 ESLOs. And so, it's not the worst thing in the world, but you really, if you're gonna have one like I did, like you really need to bust your butt and like make sure that you get in the top third.
And you told us earlier you had 17 total interviews?
Yeah, I applied to like 105 programs, and then I had like 15 or 16 interview invites, and I took all of them. So
I mean, everything that we say, obviously take it with a grain of salt, because all of our applications are different. All of our rotation sites were different. But I think you should aim for 2 ESLOs. If you cannot afford it, can't swing it, can't anything, get the OSLO, of course. But I think the general understanding right now in the EM community is not to do more than 2 EM audition rotations, because you're taking from other students. Going back to my PD, like Jared said, like he's on Discord, he's very big in all of the emergency medicine community, and his opinion is the same. Like when you show up with 3 of them, especially 3 good letters, you're kind of like, oh, look at me, I did 3 rotations, and then there's some student out there that couldn't even get a second ESLO. So I think unless you have extenuating circumstances, only shoot for 2.
Zoe, I feel attacked right now.
I'm just saying that's what everybody said. Everybody's like, only do 2, only do 2, only do 2. So I think unless you have red flags or you absolutely cannot get another ESLO, to only do 2 rotations. Anyway,
Okay.
my opinion.
And then during your rotation, during your auditions, when did you ask for your ESLOs?
I didn't. I think it's a general understanding that when you do an audition that they're going to write you a slow. So when ERAS comes out, like opens up, you have a little, I guess, prompt to send them like the request for your slow. The only caveat is make sure you know who you're sending the request to, because when I was at Riverside, it was one person who was writing the slows, and it changed in that meantime, and so I sent it to the wrong person and didn't know. So just make sure you know who to request the slow from, and you can just do that in ERAS, but I don't think you need to ask unless you're doing like an OSLO or something.
Yeah, or if you're doing a rotation off season, that's another time too, because then they assume that you are not there for an audition, and so you have to clarify, and then you've got to talk about it and contemplate and all this stuff, and eventually they say yes, but it's just kind of like you could have just said yes on the spot.
Maybe just use the keyword like, hey, I'm applying this cycle.
Yeah.
For example, I'm rotating at Broward in August, and they already emailed me like a month ago asking me if I want to slow. And then at Sinai, they asked you at orientation. Well, they asked my group at orientation if we wanted to slow or not. So I guess maybe if they ask, we can tell them.
Oh, absolutely. And they like to be prepared. So I mean, I would just mention you're going into the match this coming cycle. And if it's not an EM rotation, then of course you need to say like, hey, would you mind writing me a slow? But otherwise they generally expect that you are looking for a slow.
And just to add, like I did both of mine off cycle, like in April and May, and they'll usually still be like, okay, who's interested in EM, who's applying, like you guys are all saying. So if they don't, then you need to talk to that clerkship director and tell them that that's your intent, and then figure out who's going to write your slow. So just depending on when you do your rotation, I think they'll be queued in or not. Like Marcus was saying, just let them know right away if you're off cycle.
And then, okay, so for your non-EM letters of recommendations for Jared and Zoe, what did you guys use? Which specialty? And would it matter?
Mine was still emergency medicine. It was just an attending that I worked with instead of a slow, but you don't have to do that.
Yeah, mine was from a anesthesia attending that I did like right before ERAS opened up, and it was an OSO format. But yeah, it doesn't matter like who does it, whether it's a surgery sub-I, anesthesia, family med, just someone that can probably put some good words down for you, or they're like that knows you work very well. Typically in your sub-Is though, like you should be working, and so you should get a good letter from your sub-I, but that's why some people do a sub-I letter instead.
And Marcus, I didn't mean to exclude you. I just
No, that's fine.
I keep thinking about the 3 slows and forget that you
Listen, overkill. It's a Texas thing. It's a Texas thing. Oh, that's fine. I got my fourth letter from my I did a surgery sub-I at Jamaica Hospital in New York. And the preceptor was kind enough to write me a letter. So
Marcus, who wrote your letter from?
I'm a Turo. What you mean? Of course. That's my man.
Anyway.
He owes me a 6-pack.
What?
because he's a Giants fan. I'm a Cowboys fan. So like he owes me a 6-pack for
I was like,
football.
I thought you said he has a 6-pack. I was like,
no.
Anyway, let's continue.
So you kind of touched on this already, but how and where and when and all of the above do we upload slows to?
As soon as ERAS opens, get to it. Unless you're doing a rotation during ERAS season, then just let your preceptor know, like Katie, you're coming right before ERAS opens. I would tell Galuska, like, I need my letter for ERAS, and get those letters as fast as you can. If you do submit your application without a letter, you need to email every program that you applied to and tell them that that letter is in afterward. So get them in as soon as possible. Still submit your application even if you don't have all your letters in, but just make sure you let all the programs know when it does come in.
And with that being said, so like you only have 4 slots for any one program to see like 4 letters. And if you are going to submit a slow or a letter after you submit your initial applications, you need to have a slot opened up for that program. Because if you go ahead and fill all 4 slots, you're screwed and you can't really do much with it. So like Zoe said, it is okay to submit without all of them. Just leave a spot open for when it does become available.
And we email them once we submit it or before, like in the beginning.
As soon as you're in.
And it's kind of annoying because that happened to me. Like my Sinai EM got uploaded like a couple weeks, like right at like maybe a week or 2 after like ERAS got downloaded for programs. And I went through like 100 programs by individual email and was like, hey, it's in. It's super annoying to do, but yeah.
Okay. So in terms of scheduling rotations, what factors did you consider when you applied for EM rotations? Like, or when you picked them up, I guess.
Honestly, I feel like I just came into this like in the dark. So I found 2 programs that took raw students. In retrospect, I probably could have done better, but that's what I did.
Pretty much the same. I mean, I called Ross and asked him, hey, where are the students rotating that match an EM? And they sent me a list of 10 programs, and I emailed all those programs. And you know, the place we rotated in Virginia was on there. By the way, Zoe set that up. By the way, she set it up. So I'm giving her props on that one. Brooklyn Hospital was on the list, and then also Advent, of course, was on the list. But there were others like Kern, one in Arizona, another in California too as well. So, you know.
And a list is being compiled now. Thanks to it, the new pres and vice pres. I think we kind of started working on it when Katie and I were in the seats, but thankfully that list is coming together because a lot of us went into it without any guidance. So it's nice to have a list. And I know I preach Pennsylvania day and night, but just a reminder, you can rotate in Pennsylvania. When I was going through, I was told that you would not ever be allowed to be a resident in Pennsylvania if you rotated in Pennsylvania, and that is not the case anymore, but it was never announced. So there are other options and new programs, but luckily we are going to have that list together. So
Yeah, and I kind of just want to preface that and say that I know it's hard being a Ross student because you're kind of like you have to take what you get. But if there is a like on the list, like if you really want to go to like say Advent Health as a resident, you should try and go there. Or if you really want to like if you're from Ohio and you really want to go to Altman, like you know the area in Canton, you should try and go there as one of your like true sub-I rotations. Of course, take what you can get, but if you know a hospital that you really want to go to, I would preface that as a priority.
Absolutely. Absolutely.
And then Zoe just picked them up from the Ross website.
I did not pick them up from the Ross website. Advent, Lois told me about Advent and to come rotate there. That one I found through the grapevine. And then Riverside, I think I was just searching locations close to like where my husband lived and found that one. But now thankfully Ross has a ton of affiliate. They're still non-affiliate rotations, but they have agreements with them, and there's a lot of them out there now. The only hospital I know that Ross has not been able to come to an agreement with is Mercy St. Rita's. So if anyone was thinking of going there, Ross cannot come to an agreement with them. Otherwise, I think they've come to an agreement with most other hospitals people have wanted to go to, as long as they accept Ross students.
And then
Yeah,
Mark,
except for in New York is weird. So pretty much in New York, except for Brooklyn Hospital, anywhere that SGU students have a contract, we can't rotate there. So like Brookdale, they changed the name of Coney Island. I can't remember what it's called now, but SGU has a contract over a lot of the hospitals in New York City. So it's kind of difficult to kind of break in there where we historically was able to.
and then you said that you just emailed your person at Ross and they sent you a list of 10 places, right?
Yeah, and I cold called the programs too. Just like Cheryl called the program, like the program administrator, and was like, "Hey, I'm a Ross student.
I'm
I
coming.
would like to. I mean, not in these like actual terms, but I was just like, hey, I would like to rotate there. You know, what can you guys do? You know, so yeah."
And then Jared, you found them via how?
I went through Ross and I was like, hey, like, what's your affiliated programs? Because I'm not paying extra money. And they sent me a list of like all the approved sites for EM rotations. And I was in Chicago at the time and I was like, I don't want to drive to California. So I just drove to Ohio.
Smart. And then how and when did you apply for, like, if you had to apply for any, how and when did you apply?
So I knew that I was doing my Sinai EM elective in May of last year, but I knew I needed a second one. So I started looking around like January, February timeframe. Then I found Altman, and then I got my elective scheduled in June for in like a week. I emailed them on Monday, Friday, I was scheduled.
I applied for both of mine pretty far out, I think just because I was scared and I knew the worst that would happen was they would say like apply later. So I think I applied for my Riverside in April and did the rotation in October. So however many months that is. And then similarly like applied to Advent in like September or October and did it in February. So I did mine really far in advance. I don't think you need to do it that far in advance, but I was anxious. So
Yeah, pretty much the same. I swear, Zoe, our stories sound the same. But yeah, did mine very early, like April of 22 for rotations last year. I didn't copy you, but yeah. So I mean, because again, like the worst thing that can happen is they say no or it's too early, and then you come back. But yeah, that's it.
and I think all Marcus, yours and mine were both all non-affiliates. Jared Sinai is an affiliate, right? I don't really think there are. I don't know if there's advantages or disadvantages besides getting like the Oslo versus Eastlo. But for me at least, getting the non-affiliate rotations was very easy. Like Katie just said in the comment, that list of places they all already have agreements with Ross. So it's fairly easy. Just do it at least a little bit ahead of time, because sometimes Ross takes a little while to approve it.
Okay, and then which electives, aside from EM, obviously, did you find most helpful and useful during your EM rotation?
Trauma.
Yeah.
Trauma in Jamaica. There was a level one trauma center in Jamaica, Queens, New York, where we could pretty much practice laceration repair, suturing, INDs, ABGs, OG tubes, NG tubes. Pretty much we can do anything on any patient. Changing wound vacs by ourselves, unsupervised. So it was a good experience to have that and to just gain the confidence to be able to walk into a patient, drunk or not, and be able to repair the laceration, and then go back and do whatever we needed to do, because we were on 24-hour shifts out there. So it was brutal.
Yeah, I'll echo that and say that if you can't get trauma at Jamaica, Sinai, trauma is also level 1. It's pretty much the same stuff you see all the time, or as to what you said. Multiple penetrating traumas, so you see tons of clamshell thoracotomies, tons of lag repairs. And prior to doing my EM elective at Altman, I only been on trauma for my 30-year surgery rotation, and then just in that experience, that small experience, when I went to Altman, I felt pretty confident in helping with traumas, because where I went for Altman, it wasn't like there were no surgery residents. It was just the trauma attending, the ER attending, the resident, and nurses. So it's so much hands-on, and I felt like I was a lot more equipped and a lot more confident to actually do something useful. So
yeah, I think trauma, especially at Jamaica, like Marcus said, definitely helped. Any rotation really where you can practice, actually getting your hands on a patient, doing suturing. You're going to be suturing in your EM rotations, 1000%. You're probably going to do incision and drainages. You're maybe going to have the chance to intubate. So if you can do anesthesia, that's probably a good one. I didn't get the chance to do it. I also think a wound care rotation would probably be beneficial. I also did not do that one. So I think just as long as you have experience actually getting your hands on patients, not just doing the very chill rotations during your 4th year. I know we like to chill, but if you can get a few where you can actually get things done, that'll be really beneficial. But honestly, enjoy your 4th year. Like, you're going to do fine in your EM rotation, even if you don't have, if you've never sutured anybody in your life, you'll still be fine. So yeah, do what you can.
And I get asked this a lot by a lot of other students too, is like what electives I did. And I know Emra or just people will tell you to take whatever you want, because you'll never do it if you'll never really do ophthalmology if you go into EM, right? So you can do that stuff in dermatology, but I chose to go like cardio, pulm, ICU, and like that kind of thing. And I feel like that knowledge set that I was able to attain helped me out when I was on EM, because you're pretty much like primary until they get admitted, right? Like you have to know all that stuff anyways. So that's the route that I took, and I felt like it helped out a lot in terms of my clinical knowledge.
I actually did do op though, Jared, and I thought it was really helpful, but now I don't remember any of it.
But how many times did you use the slit lamp,
I didn't use a slit lamp, but what helped is like you learned all of the drops to put in people's eyes.
True,
You
yeah.
learned you know what I mean? And Katie, yes, there are wound care rotations, so might be beneficial. I don't know.
I think that was the last question there. Okay. Oh, I don't know what happened to number 6, but what's an ideal impressive patient presentation for ED people to evaluate you with?
This is like my favorite topic.
Short and sweet.
I mean,
Short and sweet.
yeah, it's short and sweet.
Short and sweet.
We
Yes.
all-
It shouldn't take 30. It shouldn't take 30 minutes.
Yeah,
ER docs
we're not.
all have ADHD. I mean, if you take more than 30 seconds to a minute, they're going to be looking elsewhere. So
Yeah.
go in, you as a student, go in and get that full presentation, the full physical, the full interview, the full physical exam, do everything you can think of. But when you go present it to your attending, literally only tell them the pertinent things that you think relate to why they are there. and you know, don't go in there and be like, I heard S1 and S2,
No.
you know, so short and sweet.
Yeah.
And be prepared
Um,
to give differentials and how you want to work up the patient always.
I would
When
say
you're
that's
in that
probably the
room, yeah, go ahead, Jared.
yeah, like no, I was just gonna say like that's probably like the biggest part about it is to learn that this isn't an internal medicine floor presentation. It's you need to know all that stuff in case you're asked, but you just need to get the pertinent stuff that's like 30 seconds, I mean, like to a minute long. And then what they actually give a crap about is your differential diagnoses and what your plan is. Like that's all they care about. And if you can nail that, of course you're gonna work on it. Like you're not gonna be a master diagnostician, right? But if you're like working on it and you're improving, they'll see that, and that's how they judge your clinical knowledge. Like they don't care about the presentation. They care about did you think of the 6 or 7 deadly things for chest pain,
Yeah.
right?
Right. So if you can, we've talked about this in the group, in the WhatsApp group before, but if you can lay your hands on a book, whether it be the EMRA books, which I think all of us could recommend, or any other book where you can go over differentials and work up, that's really beneficial. Even if you're like standing right next to around the corner from where your attending is, looking through your book, that's fine. But just be focused on going in there and starting those differentials in your head and asking questions based on those. Like if you go in a room and somebody, you know, it looks like it might be a PE, like start to have those questions going through your head because the attending's going to say, like, did you ask if they've been on a long airplane trip? Like, get the ball rolling in your head, but keep it short and sweet.
Absolutely. And this kind of ties into question 3 too as well. But I think on my second shift, on my first EM rotation, there's non-faculty attending told me about like as far as like differentials and how to come about making a plan. And so there's an acronym called SPIT. I don't know if y'all heard of it, where it's something serious, something probable, something interesting, and something treatable. And kind of once he told me that, it just made more sense to always have like 4 or 5 different differentials. And that, yeah, basically repetitive, yeah, have 4 or 5 differentials. And then also what saved me the most was WikiEM, by far, the app. By far, WikiEM saved me like so much time. Definitely would just like a quick preview into something and just say, hey, you know what, this person's here for abdominal pain. Well, you know, what differentials can I come up with just real quick on the fly that'll help me with my differentials and my plan. So WikiEM, please download it.
And I know this also kind of ties into question 3 as well, but and if you've ever came to any of my presentations, I kind of go over what's relevant. But if you're given a chest pain or shortness of breath and you think it's PE, like do not exclude a heart score or a perk score or any other type of risk stratification from your presentation because they're going to ask anyways. But if you
Yeah.
just say it in there, you just look like you're not a student. Like you look like a resident, okay? Like
Yeah.
just don't skip over that simple, easy trick they don't want you to know.
Yeah.
We've kind of been jumping around question 1, 2, and 3, but just to address question 2, there's a ton of things you're going to be asked to look up on MD Calc. I don't think you necessarily need to have any of them memorized. They're going to be like, hey, Zoe, look up the nexus criteria on MD Calc, and you're going to get on the computer and go nexus criteria in MD Calc. So don't feel like you need to memorize any of those. I would definitely remember like probably the heart score and like the risk factors for PE. Although even if you just have one, that's like, okay, you need to scan them. But I would just focus on getting the app for MD Calc and have it ready for when somebody asks you. But
Absolutely.
I don't think any need to memorize any of them.
No, I mean it's good to memorize the heart score because that one's just really
Okay,
simple.
heart score and
that one,
PE.
that was just really simple. Yeah. I mean, even if they're like, "Hey, what's a heart score?" You're like, "Oh," you just really like calculate it very easily. But there was just one that I thought was very interesting that an attending pimped me over. I had never heard of it before, but it's called the Alvarado score for appendicitis diagnosis. I had no idea. I had no idea what he was talking about. But that was just one that I added to my MD Calc just in case if y'all ever hear it. If you have a patient, pediatric patient, or even like a young teen or a young adult, and you're thinking that it's appendicitis, it's good to have this Alvarado score because it definitely will change how you're going about your assessment and plan, and it'll show your attending and resident that you're actually are truly critically thinking about the differentials.
So we've been jumping around. So we did we did one, we did three basically. So okay, and then so should you be presenting to the residents or attendings or both?
Depends on the program.
Yeah. Generally
I
speaking, they'll generally speaking, it should be like one student, one resident, one attending, and you'll just talk to the resident. But sometimes you'll be in that same trio and you'll just go to like the attending. It also depends if they're busy or not, if it's fast, if it's slow. So
Who should you be presenting to? The attending. Because
yeah,
that's who you're going to be presenting to in
should.
residency. Who will you present to? Probably the resident first, then the attending when the attending has time. At least that's how it was for me in both of our, well, actually Riverside, it was mostly
Oh, Riverside was straight to the attending.
yeah, but
Yeah.
at Advent it was usually the resident then the attending, which I don't mind, but ultimately you should be practicing with an attending because that is who you're going to be presenting to in residency. So it is nice to get a few of your first ones out with a resident because you're going to screw up. And it's always okay to present to the resident and the attending, but ultimately your goal should be the attending.
Yeah, sometimes the resident will even ask you, hey, do you want to present to me? Do you want to present to both of us at the same time? And honestly, if you've got the confidence that you are for sure about your plan, then go ahead and present to both and just kind of show that, hey, you have the confidence, you know, kind of what you're talking about. Maybe you don't, maybe you do, but you know, it's always good to show, you know, what you're thinking about critically.
Plus,
EM
this is your
docs
time.
appreciate effort.
Sorry, what?
I just said EM docs appreciate you just putting in effort. So
Yeah, no. Plus, this is your time to play chess as well. Like, if you're fairly confident or like you're wanting to work on your presentation skills and or like your differentials, you can always be like, "Hey, resident, I want to present to you," and like get feedback. And then over the course of you doing that and present to the attending as well, the resident can also put input after feedback or in terms of feedback, and then that kind of makes you look a bit better, I guess.
Yeah,
Like it's good when residents say good things about you, like your
yeah,
work ethic and they're improving X, Y, and Z.
yeah.
So
Or when you find something and then a resident presents it and they give you credit for it, it's really
yeah,
it's a good thing.
this is kind of related, but also unrelated, but I feel like I need to put it in here. When you do present, if somebody gives you feedback, they love it if you have that fixed by the next time you present to them.
Yeah,
So if somebody says like, please do not give me the entire cardiac exam, and next thing you're just like, heart sounds normal. They are going, that's going to be written down. It takes, it takes feedback well,
yeah.
applies feedback. So definitely, even if you botch your presentation, take all of that feedback and apply it as soon as you can.
Okay, and then I don't know if you guys have to take if any of you had to take an EM shelf for your rotations, but there are some sites that require you to. If you had to take one, how did you study? If you didn't have to, did you have any friends that did, and how did they prepare?
I did not have to take a shelf, but I had to take the SAEM exam, which Marcus did too, because Riverside makes us do it. And I also didn't mention this in the beginning, but I did do 3 EM rotations, but the third one was after I already was done with like it was just for shits and giggles. Sorry. Anyway, I had to take the SAEM exam twice, and they provide you, or at least the 2 programs I had to do it for, provide you with like a study, what do you call it, like a portal, I guess, with questions, and you can go through them. It was fairly self-explanatory as long as you're like not just doing nothing in your rotation.
Yeah.
But I did have to take that and I had to pass. You didn't have to have like 100%, but you did have to pass.
Yeah, and usually like first day of orientation, Katie, they'll let you know that you have to take that exam, or they'll let you know that you have to present like a patient or a topic kind of at the end, and they'll let you know if you have that SAEM exam. Not everyone has it, but Riverside had it, Brooklyn Hospital had it, Advent did not. They did we had the case studies.
University of Maryland has it.
Yeah.
They will tell you well in advance.
Yeah.
If they do not provide you with a resource to study, ask for it or get on the SAEM website. The test is not that hard if you're paying attention in your rotation, but you should study probably a little bit for it. So just make sure you advocate for yourself if they do not provide you with resources. But like I said, both of mine did, and I think Marcus's both did too. So yeah.
Thank you. Okay, so you guys can what are some ways to stand out?
Love
So
that we're just having you read off the slides.
so I mean, I was a scribe for years before I went to med school, so I kind of already had like what I'm about to say like came naturally to me because I've done it for so many years. But maybe Zoe and Marcus can say that residents also echo this, but it's okay, especially if it's your first rotation, to go in a patient's room and like write down information. But you kind of want to start getting out of the habit of writing everything down, and you want to get out of the habit of reciting from paper. Basically, whatever's being told to you in the room, whatever you remember and what you regurgitate is probably what's relevant. And when I was at Altman, I felt like my speed was fine for a fourth year, but my resident was telling me like you need to pick it up, you need to pick it up, you need to pick it up. So I was like, I don't know what you want me to do, but if they want you to go faster, they'll let you know. It's not anything that you're doing wrong. It's just that like when you're a resident, you're going to be seeing one patient per hour your intern year, right? So like you can't be spending like a minute just writing notes.
Yeah.
So I would say if you can do that and work on that, that's a great way to stand out.
Yeah.
It's not needed, but helps.
I think that one's important. Marcus, do you want to go or you want me to go?
I can go. That's fine.
I was gonna say ladies first, but okay. Go
No.
ahead.
Oh my gosh, what the heck? I thought you were a lot of equality. What the heck? You know what? Zoe, go first.
Okay, don't mind if I do. So, no, okay, go ahead now. I feel awkward. Go, Marcus, go.
No, you go with it. You go. Okay, all right. You put it on mute. Okay, so so things to stand out. I would say if obviously at this point you should be able to walk into a patient's room and get their history and everything, right? If you're struggling with differentials in a plan, that's okay because that can be fixed. And getting anchored down to a diagnosis, that also is a struggling thing of an intern too as well. The one thing I can say that will make you stand out is if you're good with procedures. So for example, again, like us being at Jamaica Hospital, we got exposed to so much. One thing that we got exposed to was being able to do a FAST exam with the ultrasound, right? And so in emergency medicine, they do the EFAST exam. But if you can express, hey, I know how to do the FAST exam. I know exactly quadrants. I know exactly what to look for. I know exactly how to look for the sliding lung whenever I'm doing the lung view as well. If you can, be good with that, have done chest compressions in real time, not just on the dummy in the practice course, but have actually done them real time. Like I say, suture lacerations and ABGs. If you can do those things, like it's really a good look because that's part of the slow where you'll get like honors or whatever for your procedure competency, and so that's always a good thing. I don't know, Zoe, if you had this experience at Riverside, but there was two particular physicians who they were non-faculty, and anytime they were working, they just came and found me to do all the laceration repairs. So, and that got back to faculty for my slow, and I felt like that really helped me at that site. So,
Yeah. Before I talk, I just want to say I know we only technically have 10 minutes left, but I'm happy to be here and answer anybody's questions after 8:30. So don't feel like if you have a question that you can't ask it still. At least I think everybody probably shares that. Things that came to my head when thinking about sticking out is definitely always be on time. And by being on time, I mean be there early. Do not be walking in 10 minutes after the shift starts when people already signed out their patients. The automatic bottom third for your slow. We already talked about presentations. Try to get them short and sweet as fast as you can. That doesn't come easily to everybody and it doesn't come fast, but try to get that going as fast as you can. If you have a patient that you think is very ill or going to crash soon, you go get your attending, even if you are one question into that interview. Do not stand in that room and let them crash. You go get that attending. I only ever had to do it one time and the patient ultimately was fine, but my attending was so grateful that somebody was just like looking out for this patient and that they didn't just crash in a room with students. The biggest thing I think at Advent, I really honed in on this is make sure you're rechecking your patients. They don't care if you see, 30, you should not see 30 patients in a day, but nobody cares about the number of patients you see, but more how you take care of them. So make sure, you're doing your full exam, you're rechecking your patient. If your patient needs a blanket, don't look to the nurse to go get them a blanket, go get them a blanket. Put your hands on the patient. Like we said, do that whole exam. If your patient is fully clothed and they're there for like a leg complaint, make sure they get out of their pants and you look at their leg. Make sure your patient's on the monitor. I think a lot of it is just the attendings you're working with don't have as much time as you do to go in and spend time with that patient. So if you can do that and address the little things that they need and just make sure they're not crashing in the room, that goes a really long way. And I won't go on forever, but the other thing I want to say is just make sure you're being nice to literally everybody. The janitor who's mopping the floor. Hi, good morning. I'm Zoe. What's your name? Like, thank you for cleaning. Anybody, the nurse, the tech, somebody comes down from lab, but like be nice to everybody, because I know multiple people who got into residency positions because a nurse vouched for them or a tech vouched for them, or even like the receptionist vouched, like knew their name and vouched for them to the program director. So that was a lot of things at once, but I think there's a lot of good ways to stand out that aren't just like, be the best student and know everything and whatever. Put your hands on the patient, be nice to everybody, do the best you can.
I just want to echo what Zoe said in terms of following up on your patients. Any EM attending that you ever ask, ever at any panel of anything, they'll say that's the number one thing that med students can do, because it does help them out. And like the less they have to, I don't want to say deal with questions, but the more the patient is informed about what's going on in their care, the better off they'll be. And the more quickly, I guess you can say, patients can either get admitted or discharged by keeping patients informed. And I mean, I think if anything, that's what you should be doing in the first place, is just following up.
One more thing I want to say, and I know this probably sounds like something you should already know, but don't ever lie to your attending. Don't ever say, like, if they say, did you listen to the lungs, even though the person's there because their knee hurts, don't say, yeah, the lungs sounded normal. If you did not do something, say you didn't do it and you'll go back and do it. Don't ever say something was normal if you did not do it.
Say, oh, I'll be right back.
Also be eager to, like, most people, unless you've done like an ultrasound class or something, like you may know how to do it, like a gallbladder ultrasound or like a cardiac bedside echo in your head, but if you unless you physically have done it, you probably haven't. So you do them in the ER all the time, and you can just be like, hey, like, I want to do a bedside echo, can I go do it? And they're like, do you know how? No, I'll show you. Okay, cool. It just shows that you're interested in what they do, right?
Be one, do one, teach one.
There you go.
Somebody to go watch them, then ask them to help do it, and then freaking do it. And also, the more eager you are, like Jared was just saying, the more eager you are, like the more people are gonna find you to do things. Like, I had never intubated anybody before, but I kept telling the resident I was working with, like, I really want to intubate, like, during this rotation, blah blah blah. And like, so one day the attending came to me and he's like, okay, you have 2 minutes to go read again, like how to intubate and then be in the room. And I did it, but like, they would have never asked me if I hadn't voiced that I really wanted to do that. So yeah, just don't, I mean, and also just don't be really overbearing. Okay, I'm done.
Okay, so I haven't been looking at the chat, so I'm gonna let Lindsay handle this part because I don't know what's been going on in the chat. So if people have been asking questions, then we can go with those first. If not, I don't know, Lindsay.
I think they've all been pretty much answered in the chat, like privately. But if anybody has any questions, please just verbally, you can ask them out loud now.
We're all very nice people, so if you have literally anything, no matter how silly the question, please ask, because you are very close to being in our position. Like,
That is very true.
ERAS opens in like what, a month or 2 months?
It opened today, I think.
Oh,
Did it
well,
really?
yeah.
Oh, wow.
oh yeah, it's June. Holy
Wow.
crap.
Nice.
okay.
Don't do that.
guess-
Don't do that,
Yeah.
face.
I have a question.
Here we go. Somebody has a
Goes
question.
back. Yes. Hi, I'm Tamika Love. How's everybody? And congratulations to all you guys. My question is back when you were talking about the non-affiliate and affiliate electives. So I contacted Ross about getting an elective in my state of Tennessee, but they said Tennessee was a restricted state. However, I work at one of the hospitals in Tennessee and was in contact with one of the doctors that said that I could come and do one of my electives with them. Would I be able to like go around that, or now that
You have to be
Ross
you have to be careful with that because of the
Okay.
Tennessee Medical Board. You have to be really careful with that.
okay,
So Tennessee and Nevada are the only other two states that I know of that were like Pennsylvania, in that you could rotate there, but then if you did rotate there, you could never be a resident there. So I would be very careful. I'm not positive about Tennessee. I know Nevada is like that. But if they are saying it's a restricted state, I'd be very, very careful.
okay,
Like Katie's coming to rotate with me now in Pennsylvania, but that's only after like reassurance after reassurance after reassurance that I know she could still be a resident in Pennsylvania, because you do not want to get screwed, especially out of your home state. I think you could still talk to that physician and try and like clear the air with that, kind of like how we did for Pennsylvania. But I wouldn't expect it to happen on your timeline.
I got you. Okay.
Yeah,
Thank y'all
but
so much.
there,
Oh,
but
go
good
ahead.
news though, there is a program in Nashville that matched like 5 people from Ross this past cycle. So just keep that in mind. So Tennessee is a destination for Rossies. So keep that in mind.
Awesome. Do you know by chance what's the name of that program?
It's a TriStar Nashville.
Thank you.
Geographic routes make a really big difference, even if you couldn't rotate there. If you have a connection to that area geographically, they really appreciate that. So yeah.
So, Tariq has a question about timelines, and I think I can answer it fairly broadly speaking. If you're one of the lucky people, I guess like myself, who finished cores in October, November timeframe, you kind of have the luxury of setting up your EM rotations and like getting your letters really whenever you want within the next year. But if you're like finishing cores like in the springtime or like maybe like late summer, it's okay to do EM rotations in September, October, November, December. Don't think that just because you don't have one in like May, June, or July or August, like you just can't match anywhere. It's perfectly fine to rotate into the season.
Thank you, Jared. Firstly, congratulations to everybody for graduating and becoming residents. Like you were saying, Jared, my situation, I'm probably gonna be starting course in October, so I'll be finishing those. I guess late summer or whatever the case is. So yeah, I mean, kind of like you were saying. So I shouldn't be worried about doing an EM rotation in like September, October at all.
No, but if you're starting, like you starting this upcoming October?
Yeah, this coming October.
Yeah, then
that means you'll be done next September, right?
Yeah, something like that.
Yeah. That's one of those weird tight windows about being able to get done in the next year or not. That's something that you can rotate in like August or September, October, but you need to make sure that like you're also on top of your like comp, your step 2 and all that, because you don't want to like run into an issue of like trying to get everything in its tight window and then like you just can't graduate or something like that.
Sure. Thank you, Jerry.
Yeah, and then also I don't think we mentioned it, but EM's going towards this mentality now where you should with an asterisk, you should try and get one EM rotation in, and by extension one slow in before programs can download in September, because they'll interview you based off one slow and then they'll rank you based off 2 or however many you have. So it's like 2's not needed for interviews, but 2's definitely needed for ranking.
That makes sense.
I had a quick question for you guys. I am starting my clinical rotations this July, and I know I'm a little far out to think about when the EM rotations are, but I know a lot of you have done Advent Health, and I see on the sheet it says it's affiliated with Ross. Is there an out-of-pocket cost with that? or does Ross pay for that, like with loans and stuff? Because my financial situation, I want to make sure everything lines up okay.
Yeah,
This is
financial aid should take care of it.
yeah, you do have to pay for your housing, of course.
Right.
But you'll get the money still from Ross as usual. It's really interesting because Ross like tells you you have to pay for these rotations up front, and that was never the case for me. So no, yeah. loans will
Okay, yeah, I just got like the download for like to like sign off on like for clinicals, what the affiliates are versus non-affiliates, and they were explaining like the 500 per week at non-affiliates. So I was
Yeah.
trying to understand all that, and I've heard so many different stories with it, so I wanted to clarify with you guys.
You will not have to pay, and if you did have to pay anything, which again I have not run into at all, they will tell you up front, so you could cancel that if need be.
Okay, perfect. So if I am starting around like the July timeframe, I'm going to be finishing my course early June of next year. When should I start planning on EM rotations then?
I think
I
it depends on what match cycle that you want to be a part of.
Right now, I mean, I've been told technically I could try and match for 2026.
If that's the case, then you want to probably do it almost immediately.
Okay.
It's gonna be tight though. It's gonna be
Yeah,
I
tight.
know
exactly.
it is tight. That's why I was concerned.
I would
Yeah.
start emailing programs around like February.
Okay.
And if it's
Because-
too soon, they'll tell you it's too soon, but I wouldn't be too late, especially in your shoes. So start emailing very soon and try to get them scheduled as soon as you can. Like Jared said, just try to get at least one in before the cycle, and then you
Right.
could do a couple other things and do one during the cycle and then email that the letter's in. I think you'll be totally fine to do that match cycle. It is just going to be tight. So just stay on top of it, be early with your emailing.
Okay,
like
perfect.
and
Thank you,
also
guys.
like be like if you're trying to have that for, I mean, for anybody here, like you really need to keep in the back of your head when you're going through third year, like I need to take comp at this date. This is not just for EM specifically, but like if you're trying to match in a very tight match window, like you need to take comp very seriously, and then also take step 2 and like all that very seriously instead of like just putting it off, like oh my shelf this, oh my shelf no, like you need to be on top of it.
Yeah.
I'm
Absolutely.
going to jump in and kind of touch on that a little bit because I just got into fourth year, and like Larissa, like you, I was emailing during third year what rotations are out there because I want to get my ass back to Texas. And one of the questions I'd always ask is, do you take raw students? Do you take IMGs? And if so, when? When does your market basically of electives open up? And then I would know, I got to get a reply, and like, okay, this one's April, this one's June, this one's May. And then that's when I go back to their website, which the list that Lindsay and Mooney have all created, you can kind of go to get their electives and then start picking them out, because each site, non-affiliates, they're open their windows to raw students at different times. So you really have to jump on that window, because if you miss it by 2 or 3 days,
Right.
you're done.
Okay. It's good
Yeah.
info. Thank you.
Hey Glenn, if you're interested in what is it? I think it's HCA Kingwood down in Houston. I interviewed with them, went to their second look, amazing program. The PD is absolutely amazing. Love the vibe down there. I just didn't want to be in Houston for residency.
Oh, we're going to talk afterwards, Marcus. Don't you worry.
Okay. All right. Just another snippet too on certain things, y'all. So for me, whenever I was evaluating what kind of residency program I wanted to go into, so there's a difference between academic programs, institutions, and community. And so it just kind of depends on what you want for your training. I wanted to stay away from any academic centers just from a resources standpoint. There's this program in Florida called UCF Osceola. If y'all have heard of it, please make sure you follow them. If you haven't heard of it, please find them on Instagram. They have a program highlight that I use as the benchmark for every single program that I interviewed with and also applied to as well. And the main things that stuck out to me were, the first thing is free food. That's the first thing. Like I need my food. Free food, didactics on Thursday morning. I'm not a Wednesday person, so I need it on Thursday. I need it on Thursdays. Unopposed, and also protected time for didactics on Thursday morning, because you don't want to be working an overnight shift and then have to still show up for didactics Thursday morning or Wednesday morning and have to do all that and then go back to sleep and then wake up and do another overnight shift. So certain things that you look for in programs. But if I were y'all, if you're looking for a community-based hospital, find Osceola, find UCF Osceola on Instagram. go in their program highlights. You have to scroll down just a little bit, but they've got some amazing perks that go into the program. And also for those who are interested in Advent, it's a sister program because the program director at Osceola was a resident in Advent. And so they cross-train, they meet up a lot, they do a lot of things together. I've got a bunch of friends who matched over there too as well. So just keep that in mind.
I think Instagram and Twitter are both really still underrated resources for looking into the programs you're interested in. Usually around application season, they post all of their perks. And like Katie kind of put in the thing, like look for the things that you want. I think you're going to have to come up with a list of questions before you go into your interviews, for both the residents and for the attendings. So I would have this list, like start getting this list ready in your head. What is the food situation at your hospital? How much do you get for food per year? What's the parking situation? Do you guys have a lounge? Are your didactics protected? Have these questions ready ahead of time so that you can either go to a meet and greet, or you'll probably be interviewed by a resident so that you can ask these questions there. I say stalk, but I don't actually mean stalk, but look at them on Instagram and Twitter and any social media and see how the residents interact. I mean, yes, it's social media, so it's probably a little bit fake, but you can still get an idea of how close-knit the residency program is. What else do I want to say?
So everybody come to Florida. So everybody come to Florida.
No, Pennsylvania. Anyway.
I was gonna say, by looking at their Instagram pages too, sometimes depending on how active the residents are, because it's usually resident ran, depending on how active they are about posting like what they do in terms of like what they do during didactics, if they're having a fun day, if they're not, they're having, I don't know. But it can also highlight their wellness, and that's huge for a lot of people, especially in emergency medicine. You see it every year. EM is the highest burnt out specialty. So in residency, like wellness is a huge thing for most programs, and so you can kind of judge their wellness by their Instagram potentially. So yeah,
wellness is a very hot topic in emergency and medicine in general, especially in emergency medicine. Join my wellness committee. Anyway, but seriously, be prepared to answer, what do you do to take care of yourself? How do you stay well? Because you will be asked that. For me, since my application said like vice chair of wellness committee, they were like, what does that mean to you? What do you do? Like, how do you stay well at home with a baby and blah, blah, blah. Just be prepared to answer questions about how you take care of yourself, because we all are burning out like no other.
Yeah.
Katie, are you raising your hand? Go ahead.
nice.
So I have a comment and then a question. My comment is also something that I didn't realize to ask until this last weekend, is if you like to go to conferences, like Zoe said at the beginning, we're big AAEM people. There's lots of people who have gone, and if you haven't gone, you should go because it's a fun time. And anyways, that there's some programs that make you go to conferences, but it's on your wellness time. Like it's your time.
Yes, you're right. Yeah.
And to me, that should be different, because I mean, you're also working, and like if you want to take off, like you should be able to take off and not have to go to a conference if that's not your thing. So yeah, that's just a comment that I didn't know was a thing until this weekend. And then my second, my actual question is, do you guys know how long it took for your eSLO to be submitted or uploaded, like once you requested it?
It's all dependent on the program director. Altman PD did mine. Like I sent her the request as soon as it was available. Like I think like on a Thursday or Friday. Monday it was uploaded. But then like my other soul from Sinai took like 3 months.
Okay.
So
yeah, same with Brooklyn. Oh,
Don't
what
be
are you
afraid to, I was just gonna say, don't be afraid to be on top of people if your letters aren't uploaded. Katie, Lois, I had to email her 10 times probably to get my letter in. That was not a slow, but still. Usually programs that have are more situated in their rotations will get them in faster. Like Advent was fairly quick. Riverside was really quick, I think. But usually when you request them, it'll take a couple weeks. They'll submit it for IMGs. There's some weird process the letter also has to go through. So you'll get like an email that's like, oh, your letter's been uploaded, and then a few days later it will actually go into ERAS. So just keep an eye on that. But I would expect a few weeks between doing the rotation and having your letter at the bare minimum. But stay on top of people. John, are you raising your hand? I love this in the comment. Oh.
Somebody
Yeah,
raising
sorry, I was raising my hand. Yes.
Okay.
So I may be completely too late for the game here. Let me tell you a little bit about my situation, get your guys' take on it. So I'm halfway through fourth year right now, and EM was not on my radar at all until I did an elective in Pontiac back in April, and I fell in love with it. But now, like, I'm questioning if it's even feasible to be able to get all the requirements in time.
You're fine.
You're going into this cycle?
Yes, 25. Yeah.
I mean, can you get a second EM elective?
Well, that's the thing too. So I'm confused about this slow thing because Pontiac doesn't have a residency program, and I heard, even though I got a letter from the director there in Pontiac, I'm not sure if it counts.
John, I know a place where you can get in literally Monday, Brooklyn Hospital. The way they run, if you want to go to New York City, you can go to Brooklyn Hospital, literally call them up, and they will be able to get you in like within the next week starting, just because of how oddly they run things at their program. I mean,
Okay.
and it's not like a last ditch effort. You're going to get a solid rotation, but if you just need something like emergently, I would look into the Brooklyn Hospital Center.
Same
Okay,
with
I'll take
Altman.
that.
If you email them any day, like the person, like the point of contact, she'll email you like almost immediately. I mean, they're very good and very friendly there too.
Yeah.
Thank you, Jared. Where is Altman?
It's in Canton, Ohio.
Can't. Okay.
I just
Hall of
typed both.
Fame.
Hall of Fame.
Exactly.
John, you did it at Trinity Health Oakland, right? Is what you're saying?
That's correct. I did.
Yeah. So you won't get a E-slow, but you'll get a slow.
Oh, okay.
You have
Okay.
one secured. I don't want you to like panic too much from what it sounds like, but you like ideally what you would do is get another E-slow or get a E-slow.
I don't know if y'all put Brooklyn on the spreadsheet. I think someone just asked that just now. I don't know if it is or not.
I don't know.
I don't know, but we'll add it if it's not there yet.
Okay, yeah, it's a 4-year program though. That's the only thing. But they love raw students. It's a lot of SGU students who rotate through there. But it's a program that's definitely resident ran. The attendings just kind of sit there and just wait for you to present to them. But you get a lot of procedures. You get a lot of like starting IVs. It's right there in the Fort Greene area of Brooklyn, if y'all are familiar with New York City. So it's like crazy as heck. Very crazy.
John, I think that you will be okay going into the application cycle. I do think you should try to get an E-slow if you can. But as long as you are prepared to write kind of in your personal statement and in your interviews how you came to know that you wanted to apply EM, I think that's the harder thing to do. Like the EM is very big on like people who have known they wanted to go into EM. So I think as long as you have some kind of like a little story about why you suddenly wanted EM, I think you'll be totally fine. I think the one slow, and then if you can get an E-slow will be great.
Okay, perfect. Thank you for your input on that. Yeah, I mean it's interesting. Like a lot of you guys I've noticed from listening, that's kind of always been your thing, your target. And with me, it's just it happened accidentally. I didn't know that it would be something I enjoyed so much.
A lot of people don't know until they get to rotate through the ED. I think all three of us had some kind of background in emergency medicine. So if you don't have that, I think a lot of people don't know until. So yeah, like I'm saying, I think you'll be totally fine. Just make sure you do have that little tidbit prepared, because they're going to be like, why do you want to do EM when your application doesn't scream EM? But we take in everybody and anybody who loves us. Please come to us. So.
Thank you.
Okay, I don't know who was, there's two little hands raised, but I don't know which one was first.
Omar was first.
Omar was first.
I have a question for Marcus. So
Mhm.
I'm actually from Orlando, and like Orlando is like literally 5 minutes from my house.
Yeah.
So that's that's a perfect hospital for me if like to do like an elective there, and like if I can match there eventually. So my question to you is, why did you choose Advent Health as your top choice? And I know like they have two different locations. They have the east location, and then you have the main hospital. So for the residency program, do you end up like going to both of them, or do you go to the main hospital, or like how does that work?
So you do, so the actual program is at East, and then all the other rotations except for trauma are all at South, which is what it's called. The one downtown is called South. And then you do your trauma for a month in Miami. I chose that program simply because of the staff, because of how I felt once I was there. I kind of felt like a family team, and also because one of the attendings, like on my second day, literally had college football. He was looking at the schedule for the UCF Knights, and I was like, "This is amazing. I've been in New York too long. Nobody watches football up there." It was really pissing me off. so the fact that I could sit there and just talk with the attendings about anything, and just kind of just talk football mainly was what really sold me. And then just everything else that I rotated there last June. Literally at this point last year, I rotated there, and I was there when the residents were graduating, so they took us out to dinner. They had like parties at their teens' homes, and so really just showed me what the program is. And again, it's Florida. Florida man is real, so you can't beat that.
I'm gonna talk on this too because I rotated to Advent, and literally if they were not in Florida, they would have been my first choice. Mind you, I'm extremely happy I got my first choice in Pennsylvania, but Advent had my heart for a really long time. I told my whole family I was gonna uproot them and take them to Florida. It was a whole deal. They say that when you go through your rotation, like you're going to know when that's the program for you. Unfortunately, I mean, I have my feet in two places that work for me, but Advent is a really great program. So if anybody wants to end up in Florida, definitely recommend.
Yeah, I definitely recommend Advent as number one. My number two is Osceola. Again, Osceola is really good, really great program. It gives you the same feel of Advent as well. In South Orlando and Kissimmee. Lakeland is another good one in that Central Florida area as well. Lakeland is the busiest ED in the nation, which is like really crazy to think that some small town in Florida is the busiest, but it is. So yeah, if anyone has any questions about Florida programs, just reach out, because most of my interviews were in Florida and Texas. So yeah.
Just don't go to any HCAs. Anyway,
No, don't listen. Do not listen. Okay, listen, y'all. Do not listen to Zoe on the HCA. Listen, you'd rather match than you would rather match at the ACA program than not match at all. I'm telling you this right now.
No, I wouldn't.
Not all ACA programs are the same.
HCAs, you can never get your loans paid off by your job. They do not allow that, like never.
3 years.
No.
Yeah, it's only what I'm saying is it's only 3 years.
You lose 3 years out of 10.
But you know how much they're paying once you're going. Hold on, listen. Do you know how much they're paying out when you're doing residency? ACA programs are paying the most out of any program.
Here, Katie's asking what's the deal with HCAs.
So the deal with the ACA is
they're for profit. You're fine, Jared. I could rant about this all day.
Yeah, same.
They are for-profit hospitals. They don't look out for you. You will not get loan forgiveness. If your HCA hospital shuts down, many programs are not going to take you in as their resident.
No, that is very true. However, and I'm not even going to an ACA program, but I do defend them because, again, there's a lot of raw students who match at HCA programs, and I have nothing but good things to say, especially the ones that I interviewed with. Like I interviewed at Kendall, in Orange Park, and Brandon in Tampa, and like the staff is great. Your residency program is going to be based on the staff that's there. And again, there are some bad ones, of course, but when you're done residency and you got that HCA job offer and they're offering you $500,000 base, you're gonna take it. You're tripping.
You're part of the problem.
You're 500,000. 500.
Part of the problem, Marcus.
500.
Anyway, HCA, like I said in the chat, HCA should be your last choice, but it can still be a choice. But I strongly recommend, and if you're a part of AAEM and you go to an HCA, you might as well say bye to AAEM because anyway, should we get to the other two questions or are we still gonna talk about HCAs?
Andreas has been waiting forever.
No, you're good. I had a quick question. So basically, let's say if I get my first slow in September, because I'm scheduled for my first EM elective in September, and then I get it before the application starts, which would be in September, but then just to clarify, because I know we touched base on this, but if I got the second letter later in the cycle, would that still be okay?
If you got a second later, but later in the cycle?
Yeah, like even if it's like, let's say October or November, like would
Yeah.
that still be okay?
Yeah, that's totally fine. Just make sure that you do email literally every single program you applied to and tell them that the letter is in because they are not on top of it to look for that letter. So that's totally fine. I would definitely still submit without that letter because as long as your application gets to them, they can still offer you an interview. If not, you're getting moved down the line in terms of interview spots. So definitely still apply and then send them an email once you get that letter in.
Okay, thank you for the clarity. I appreciate it.
Of course, sorry we were doing a long rant before answering.
No, you guys are good. I was listening to that too.
We've been arguing about it for a while now, so. Listen, Zoe, listen, I'm upset at Zoe because she was supposed to be my co-resident. And when she told me that she wasn't going to rank Advent as one, I was just like, wow, you have turned the tide on me. I thought we were going to be co-residents. We were going to just be, chief residents and everything. And
Marcus, I want you to start residency with an 11-month-old and your husband deploying in
I
the
know.
I want you to tell me to move my family to Florida. Anyway,
Marcus,
Jerry, what you about to say?
Yeah, I mean, like I'm part of the Henry Ford system, and I get discounts as an employee at Ford Motor, Stadium. So if the Cowboys ever make it and play the Lions in the playoffs, you always come up north.
You're asking. Listen,
if the Lions are going to the playoffs, I want to go.
You're asking for a lot, Jared. Cowboys we're not making the playoffs this year. We're not making the playoffs this year.
I mean, it's probably true, but
Jared and Marcus, should we all just drop our contact info real quick and then Mooney, we can still, I'm happy to still stay and answer stuff. Since people are slowly leaving, let's drop our contact info real quick. And then Mooney, what's up, girl?
You're muted.
You're muted.
The person asked me privately, so I just wanted to make sure that they were not acknowledged. When you guys are talking about the top third, middle third, and bottom third of a slow situation, can you guys clarify that? Because they were asking about it.
You're probably best at this.
Again, so the question is basically differentiating between top, middle, and bottom third of the slow. It's a subjective ranking that the program does to you based on how well they think you performed in the rotation. Because if you look at the format, you can download the slow on the on the internet, and there's different categories, and the way they rank you is basically you're performing at an intern's level or you're not performing well as a student in general. Generally, you'll fall in the middle, as if everybody should fall in the middle. But then if you've if your presentations are fantastic, you're intubating all the time, your lac repairs are fantastic, you don't miss a beat, you'll go in the top third. It means out of the entire cohort for EM in that cycle, you're one of the best of the best. But sometimes you might start out your first rotation and you're learning things and you might get middle third. It's not bad per se, but you just want to improve upon it. And again, that's why it's a very subjective thing for when you're being looked at. That's why you want to always be looking at or going back to your patients and doing proper follow-up. You want to be, taking that feedback after every shift and incorporating it, because that's what gets you into the top third, not knowing everything off of step 2.
I was looking at one of those slows, the ones that you said that we can download, and it asks them which number rotation. I mean, not rotation.
Yeah.
I feel what you said, that eventually showing progress is good too.
Yeah, that matters as well. If it's your first one and then you're lower or middle third, and it's whatever. But if it's your second one or your third one and you're middle third, that's kind of, I'm not gonna say weird, but they look at that. But if it's from middle or lows third, and then like the next one is like a rank up or two, you can tell that this person like took feedback, did better, they learned from their mistakes, whatever the case may be.
Also, like something I did on my rotations was like schedule an exit interview. Ask them,
That's huge too.
you know what I mean? Because then you have an idea of what your eval's gonna say. And your slow. They won't show you the exact slow, but they'll give you an idea of like where you're ranking and so that you know if you like, if you're like Marcus and want to overachieve and do 6 ER rotations, just like but you can, you know what I mean? You can get an idea if you need to do another one or if there was a red flag. If your last, like Jared's saying, if your last rotation is bottom third, like you're like degressing, like maybe you need another one to prove that you're not, that was just like a fluke or something. So definitely do your exit interviews and get tons and tons and tons and tons and tons of feedback every shift.
I think along with that, it's important to note that when you go into this audition rotation in emergency medicine, you are expected to apply your slow to your application. If you do an emergency medicine rotation and you get a slow from them and you do not apply it to your application, that is going to be a red flag because people are going to wonder why you do not have a slow on your app from that program. Were you an awful student and you didn't so you you have a bad slow and you didn't apply it? Because I was worried, to be very transparent, I was worried about my e-slow from Riverside because the rotation was really bad for me. And I talked to the remake advisor at one point in time and said, like, can I just not apply this to my application? Because I didn't know what it was going to say, but I didn't think it was going to be good. And he said it's a huge red flag to do a rotation there and not get a slow. So even if you can, make it look better with another slow, I would go into any EM rotation that you have absolutely ready to do your best. Like, don't mess around because that's your future. And if something extenuating happens, somebody passes away, unfortunately, or something really bad happens, communicate that with the program so that you don't look bad because of it.
So my question has a tie in with this. So if you do 3 EM rotations, then you upload and you get a slow and an e-slow and whatever else from there, you would upload all 3 and then a 4th, like another specialty letter, correct?
Yeah.
But you make sure you upload all 3. If you have a slow,
that's the advice that was given to me, is that if you do an EM rotation, you should have a slow to go along with it.
And it should be uploaded.
Yeah.
Okay. Thank you.
Anya?
Okay, so my question is about e-slows as well. Sorry, you guys. So the e-slows that you get from a residency program, it's from the whole program, right? Because I mean, when you go in, you're rotating with different doctors every day. And so is there like multiple people weighing in on your final slow? And so, you know what I'm saying? Like, is it more weight with one person or another, or?
There's usually some kind of system, like people are evaluating you, whether it's like you giving them a QR code on your phone or like they have paper forms. At Riverside, it was paper. At Advent, it was a QR code. And at the end of your shift, you have to have your attending fill it out. Obviously, if you work with an attending more than once, they develop a better relationship with you and they can speak better about you. But everyone's kind of weighing in. Usually you don't have to ask every single person you work with. They'll say like, oh, get 8 evaluations or something by the time you're done. So if you have a really bad shift with somebody, you don't necessarily need to ask them for an evaluation. But I would definitely get people who you really vibe with to evaluate you in whatever shape or form they have at their program.
Okay, yeah, that makes more sense. And then so for the OSLOs, like for like other like maybe cardiology or whatever, that would be just that one specific person that you rotated with, probably, unless it's like another residency program for like anesthesia or.
So when you send the letter of request in ERAS, it's gonna like you have to type in the attending's name and their position and put in their email, but it's gonna have a generic pre-typed up text of how they can submit a letter. But if you want an OSLO, you need to do that, but in the text box, you need to include the link that's from the OSLO website. And then and then put it in the thing, and then they can click it and then fill out the form and download it, upload it. But yeah, it's typically just like an attending in any other rotation, anesthesia, cards, whatever.
Okay, thank you. That makes sense.
No, also be also be a little like whenever you are like evaluating programs and stuff, make sure you are paying attention to like what level trauma it is. I know a lot of times it doesn't really matter. Like for me, trauma doesn't like the level of trauma really didn't matter as much because I'd rather be away from a level one. I didn't want to actually be at a level one just because of the resources and everything. But you know, some of the programs will do it where like, oh, well, trauma team has the patient's left side and EM has the patient's right side and anesthesia has the airway, you know. So those are, you know, different things to, you know, ask about whenever you are interviewing, you know, programs too as well. So just keep that in mind.
Yeah, I think that's definitely ask about your role
Yeah.
in a trauma. Because yeah, like Conema, where I'm going is a level one trauma and Advent is not. So I was like literally between the two. But at Conema, you know, you rotate through trauma and you're obviously in the ED. So ED has head of bed, you know, and then they intubate and all that, and then trauma has the rest. But you spend a lot of time with trauma as well. So you get both of those, but make sure you do ask that question because like Marcus said, these are really academic centers. There's like subspecialty on subspecialty on subspecialty. So what you get to lay your hands on gets more and more limited.
Well, make sure y'all apply to Jefferson Stratford. I like them. They were awesome. Man, they were really. That was like my favorite. Probably one of my favorite interviews I was on. They were
They're
great.
in New Jersey. Anyone who's wondering, Jefferson, New Jersey.
Yeah, New Jersey. It's right across from, well, I guess Philly, right?
If you can deal with the cold for a couple of years, there's a lot of good programs in Michigan.
Yeah, there are. Yeah.
There are just a crap ton of good programs out there. So you just kind of need
Yeah.
to, I mean, do apply broadly. I'm not saying only apply to 10 programs. Do apply to a lot of programs. I think 100 is way too many, but then you can kind of sort out where you really want to go. But make sure you're safe first. And especially if you have anything that you need to explain on your application, I think it's more important to apply to a few more programs. And I guess since people are running out of questions, I'll just say the last few things I was thinking, but just make sure you can speak about your application. If you're going to write something on your app, be prepared to talk about it. They really like to see things that you're passionate about, even if it does not relate to emergency medicine at all. If you like to bake cookies every Sunday and you put like, I don't know, Cookie Sunday or something on your application, people are going to love that. They're going to ask about that. Be prepared to talk about that. They want to see that you are somebody outside of medicine, but also have your passions in medicine. I don't know. You guys are losing me at 9 p.m. My baby goes to bed at 7.
I did just want to like touch on one thing very briefly. It's a broad topic, but it gets brought up every single year. Like, should I apply to 3-year programs or 4-year programs? And the answer is it depends what you want. A lot of 4-year programs are from academic centers. There's not very many that are community based. There's a couple, but in general, it doesn't really matter. There's pros and cons to both. The caveat is that if you go to a 4-year program, no matter where it is, you can go work at any ED in the world, at least in the States. But if you do a 3-year program, and you want to move to Boston and you want to work at like Brigham or like Mass Gen, you can't if you go to a 3-year program. They want people who did a 4-year program or did fellowships. So that's something to keep in mind for like job wise, like way down the future. But in general, like 3 versus 4, it doesn't really matter in the long run of things. So
Jared, yours is 3 or 4?
Mine's 3.
3, okay.
Yeah.
Yeah, I got 3 as well.
Yeah.
Yeah, I think I only applied to 1 4-year program.
Same.
If you look at my Excel sheet, like when I declined interviews, the reason will be like 4-year program.
Actually, no, probably more. New York City and Michigan have a lot of 4 years.
Yes, they do. And there's one, I actually think it's Mount Sinai in New York. Their 4-year program, they have 24 resident classes. Like,
yeah, it's huge, right?
It's huge.
Yeah.
It's mad. I'm like, what the heck?
Yeah, I think I don't know if I applied to, I either applied to them or Maimonides, but one of them offered me, and I looked at it and I was like, holy crap, why did I apply here? And I declined the interview.
There's also one that a lot of raw students don't know about. It's in Rhode Island. If you like the Northeast, it's called Kent. Kent. Yeah, Kent is a community-based program, but they're affiliated with like Boston, I think Boston Medical. They're affiliated with a couple other programs, but I know in like first and third year, you go to shock trauma for trauma, and it's just like they have really good training. It's kind of like a hidden gem, but you can also do a fourth year elective there for a slow. And it's not on the roster because like one of their current, I think now PGY2s is a Ross graduate, and he did his fourth year elective there. And it's simple. It's a paper thing. Like, do you want to come rotate here? Yes. Okay, cool. What's your email? So Ken's a good one if you care about the Northeast. It's like apparently it's an hour away from Boston on a train ride. So if you get day off, you can go to Boston.
Sounds cold.
Yeah.
I could draw, seriously.
Well, if nobody else has questions.
Thank you guys so much for doing this.
Wait, I gotta drop my last 2 cents, guys.
Oh, yeah, go please.
Mic drop, go ahead.
Everybody who's here, if you're applying this cycle, you can do it.
Yeah.
No, but seriously, you can. Like Marcus and I, before everybody was on, we're comparing our step scores, and they're just like literally not great. And we both did absolutely, Jared did absolutely, we all did. I don't know what Jared's step scores are, but we all did absolutely fine. Just make sure you're prepared. I guess, yeah, ERS is already open, I guess, but, get online and do a little bit of research about the most commonly asked questions for EM interviews. Have your list of questions ready going into your interviews. Have your little spiels kind of practiced for how you're going to talk about your application and what's on your application. If you need help putting together your application, reach out to me, reach out to Marcus, reach out to Jared, reach out to your mom, reach out to your uncle, have anybody and everybody read your application if you're worried at all about it. The more eyes, the better. The one thing I want to say, if you haven't already written your personal statement, is the best advice I got was if somebody else could write your personal statement, it's not personal enough. So, don't write about how you get sad about seeing a patient, because we all get sad about seeing certain patients. Like, make it very personal, even though supposedly it's a very small part of your application. You're all going to be great. Emergency medicine only cares that you're, wanting
a human
hard, personable. You can sit next to somebody at 3 a.m. and still have a good time while you're working. And if you guys need absolutely anything, all of our contact info is there. I don't know anybody who matched EM this cycle that would not be willing to chat with you about anything and everything. So none of us have made it this far without help, and we're happy to help anybody.
Absolutely.
Thank you so much for being here and putting in all this time and effort to answer all these questions. We're super grateful, and we're super happy to have you guys as our family.